Um, Oh. Hello, can all of you hear me and see my screen?
Yes.
Okay. Why are there so less students today? Only 39 students are here today. This is alarming. Okay. Okay, first of all, any questions regarding the last lecture? Okay, yes, okay. So, any questions regarding the last lecture, right? All of the physiologies are very important, right? Yes, Dr. Aisha. Actually, my best. Yes, Dr. Aisha, how does hypoglycemia affects growth hormone? Right. Okay, guys. So whenever you want the secretion of growth hormone in the body, right? Whenever you want the secretion of growth hormone in the body, you need hypoglycemia for it to occur, right? You need hypoglycemia so that the secretion of growth hormone can occur. And this is an evolutionary mechanism in our body. Why? Because if you are having hypoglycemia in the body, right, you are needing more amounts of energy, right? So whenever you are needing more amount of energy, growth hormone is released, and growth hormone is going to do the lipolysis, and that is going to increase the energy reserves in the body. So whenever you are having hypoglycemia, that is going to affect the secretion of growth hormone, and that is going to increase the secretion of growth hormone, right? So that is how hypoglycemia affects the growth hormone, right? So other thing, guys, is that please, physiologies are really important. All the pathophysiologies, you are welcome, Dr. Aisha. So all the pathophysiologies are really important, right? I want you guys. So believe me or not, yesterday I was just scrolling on the Facebook and I just came across a tutor and his videos, and they were so useless, right? So please play pay a proper focus on these physiologies and these pathophysiologies, right? All of those are very important, right? So please pay a good focus on these, right? So with that, now we are going to start the most one some of the most important hormones in the body, right? The
Dr.
most
Moss,
important
I have
hormones
one
in the
question.
body. What are you saying, Dr. Ume?
Uh, I have one question. As you said, hypoglycemia increases the secretion of growth hormone. So, but hypoglycemia is not good for health. If someone is hypoglycemic, so their blood sugar glucose is going down. So, isn't it
Yes.
dangerous?
Exactly. Yes. So that is my point
So,
too, right? So you just explain my point, right? How? Because whenever you are having hypoglycemia, that is very dangerous from the body, right? That is really
yeah,
dangerous for the body. So what does the body do? The body does two things, right? So the body will only do one thing. So whenever you are having hypoglycemia, hypoglycemia is extremely dangerous for your body. So that is why the body is gonna secrete the super hormone, which is the growth hormone, right? What's wrong with this thing? Seriously? Okay. So the body is gonna secrete the growth hormone whenever there is hypoglycemia, because hypoglycemia is very dangerous for the body. And growth hormone is gonna do two things at the same time. First of all, it's gonna increase the lipolysis. Why? Because hypoglycemia is dangerous for the body, and you need any additional fatty reserves, right? So you need additional sources of energy. That is where lipolysis is gonna play a very important role, right? It's gonna provide the ketone bodies, and it's gonna provide additional sources of energy so that glucose is not used up, right? So first thing is that growth hormone is going to increase the lipolysis, so the body does not consume more glucose and the body does not go into a dangerous state of hypoglycemia. At the same time, I told you yesterday, growth hormone is a diabetogenic hormone, right? Growth hormone is a diabetogenic hormone. It is going to increase the insulin resistance, right? And as soon as the
Yeah.
insulin resistance is going to increase, right, there is going to be hyperglycemia, right?
Yeah.
So that is why in hypoglycemia, growth hormone is secreted because it is a very dangerous trait. So hypoglycemia is a very dangerous trait. So the body combats hypoglycemia by two things. So there are a lot of mechanisms by which the body combats hypoglycemia. The body is going to secrete cortisol. We are going to see how cortisol counteracts the hypoglycemia. Then we are going to see how epinephrine is going to combat. So one way is that the body secretes growth hormone, right? And how does growth hormone combats hypoglycemia? It's going to increase the insulin resistance, so the body does not go into, so the body goes into the hyperglycemia. And the second thing is that it's going to increase the lipolysis as well. And in this way we are going to get the body out of hypoglycemia, right? And whenever the body sees that there is hyperglycemia, the growth hormone secretion is going to stop. Okay. So now we are going to do the thyroid hormones today. Right. So we have two. So the thyroid. So where are the thyroid hormones produced? So the thyroid hormones are produced in the thyroid gland, right? And thyroid produces two hormones. One is the T3, which is known as the triiodothyronine, and the other is the T4, which is known as the thyroxine. Right. The most important thing is what is the main component of these hormones, right? So the main component of these hormones is the iodine, right? So iodine is the main let me try one other thing today. So this is better. Right. So, okay. So the body is gonna do iodine, right? So there is gonna be iodine and okay. So the body's so iodine is the main hormone, right? So iodine is gonna do all the things in the thyroid hormone, right? So we have iodine, and that iodine is going to be the main component of thyroid hormone. So T3 and T4 both are the thyroid hormones, and iodine is the main component of it. Why is this thing important? So this thing is important, right? So this thing is very important. Just give me 1 second. Okay, so this thing is important. The iodine hormone is very important. The iodine thing is very important because a lot of people are gonna have iodine deficiency in the developing countries, right? So if they give you a question that a person comes from the developing country and that person is having hypothyroidism, the first thing that should come into your mind is iodine deficiency, right? Now, one thing that is important here is the fact that a lot of questions are related to the socioeconomic status of the people or the patient where the person is coming from, right? So if a person is coming from developing countries, the reasons for different things would be very different from if versus if a person comes from a developed country, right? So if a person comes from a developing country, the first thing that should come into your mind is this person may be having if there is deficiency of thyroid hormone, then this person may be having uh, iodine deficiency hypothyroidism, right? So that is the first thing. Now let's let's move forward, right? So now first of all we are going to see how is the thyroid hormone being made, right? So how is the thyroid hormone made? So let's focus on this diagram here, right? So first of all, whenever we are eating anything, that some things contain iodized salts, right? So that thing is going to contain iodine and it's going to also going to contain sodium, right? Now this iodine and sodium is going to go inside the body, right? And this is going to go inside the body with the help of a transporter, right? So first of all, the iodine is going to go inside the body and it's going to go inside the cell, right? And after that, iodine is going to get converted into the iodized form, right? And then it's going to combine with the thyroglobulin and it's going to form the thyroid hormone, right? Now, the first thing that the main clinical point that is important here is the fact that thyroid, so we have a hormone which is known as the T4, right? So the T4 is known as the thyroxine, right? So the T4 hormone is the thyroxine hormone. whereas the T3 hormone is the triiodothyronine hormone. Right? Why is this important? Because T4 is the main active component of thyroid hormone, right? T3 is the main active form of the thyroid hormone, right? Whenever a body needs to do anything, it's gonna do that thing in the form of T3, right? T3 is gonna drive all the functions of thyroid hormone, not T4. T form is the storage form of the thyroid hormone, and T3 is the form that the form that we need for ourselves, right? So T3 is the form that we need whenever we are going to do some functions of the body, and T4 is the form that is the major thyroid product, and it's the storage form, right? Now, how is T4 converted into T3? So, in order to convert the T4 into the T3, we are gonna need a 5 deiodinase, right? So the 5 prime deiodinase. So T4 is converted into T3 with the help of 5 prime deiodinase, right? So first thing is that whenever there is peripheral conversion, that thing is done with the help of 5 prime deiodinase, right? So whenever there are a lot of T3 in the body, it is due to the fact that we are having 5 prime deiodinase and that is working very hard, right? Now, why is this thing important? This thing is important. These concepts come into the play whenever a patient is having thyroid storm. So what is thyroid storm? So whenever we have a lot of thyroid hormone in our body, whenever there is a lot of thyroid hormone that is present, the fact is that we are going to have tachycardia, we are going to have fever, we are going to have high blood pressure, we are going to have shaking, we are going to have tremors of our body. We are going to have all of those things, right? So the first thing, the first pathophysiological aspect that is important here is now we are going to stop the thyroid storm. So how can we stop the thyroid storm? So in order to stop the thyroid storm, we give the patient three things. First of all, we give the patients glucocorticoids. Secondly, we give the patients beta blockers. And the third thing is that we give the patient propyl thiouracil. And all of that work on the 5 prime deiodinase. All of them are going to block the 5 prime deiodinase. And when 5 prime deiodinase is blocked, you are not going to get any more T3. And when there won't be any more T3, you are going to get less amount of thyroid activation all over in the body, right? Okay. So this is the first thing that is important here. Now we have Now, for what are the functions of thyroid hormones, right? So, what are the functions of thyroid hormone? So, remember, only the free hormone is active, right? So, thyroid hormone is not, the thyroid hormone is carried in the body with the help of some storage forms, right? But when T3 is free, it is going to combine with some things, right? So, what is the mechanism of action of thyroid hormone? So, remember this thing, thyroid hormone acts on the nuclear receptors, right? So thyroid hormone is gonna inside the cell, and inside the cell, it's gonna go in the nucleus, right? And there is gonna be nuclear receptors, and the three is gonna bind with those nuclear receptors. And then whenever a hormone binds with the nuclear receptor, keep this thing in your mind. Whenever a hormone binds with the nuclear receptor, it's gonna lead to the formation of new proteins, and then that is gonna lead to the formation of different functions and different products, right? It's no So all the hormones that act on the nuclear receptors, all the hormones that act inside the cell, right? They do not act on the surface receptors. All the hormones that act inside the nucleus, they are gonna act by increasing the transcription, right? They're gonna act by increasing the transcription, and when the transcription is increased, the translation is gonna be increased. So and then transcription means the formation of RNA, whereas translation means the formation of proteins. So new proteins are going to be formed, and then those new proteins are going to go a lot of function, right? So the first function that thyroid hormone does is very important, is that it's going to lead to the formation of brain. It's going to lead to the brain maturation, right? So why is this thing important? Does anyone know what is cretin, or what is cretinism?
Reduce growth.
Congenital hypothyroidism
Hypothyroidism
Congenital hypothyroidism.
in children.
In children.
that's like stunted growth and mental
Yes.
retardation in
Okay,
children
so okay,
Congenital
good. So now tell me one thing: why is it called cretinism?
because it's congenital hypothyroidism or
Okay, so,
childhood hypothyroidism.
but why do we call it as cretinism? Anyone?
I think due to yellow discoloration.
Okay. So this was the question that was asked to me by my final year examiner in the surgery, right? He was Dr.
Creatine
Sayyid
means,
Uskunaki, and he asked,
can I
Is
say?
it the mental
yes, yes,
retardation?
yes,
Yeah, some dumb. It's used like sort of a bad word for someone
ex-
who is dumb or intellectually like disabled, sort of
exactly. Oh my
dumb.
God. Yes, exactly. So
Yeah, that's
creatine
correct.
was a slang word, right? So it was an abuse word in Greeks, right? So in Greeks, whenever a person was very dumb, we called that person as a cretin, right? So whenever a person was very dumb, that was an abusive word or a slang word, and that mean that person was very dumb. So we call that person as a cretin. And from that Greek word, we now have cretinism, right? So cretinism basically means a very dumb person, right? A dumb person by birth. And why is that? Because whenever a patient is born, whenever a baby is born, that baby is gonna need thyroid hormone for the brain maturation, right? And if a person does not have thyroid hormone, there is gonna be no brain maturation of that person, and that person's brain is not gonna be matured, right? So the IQ is gonna be very bad. Now they could ask you a question that a patient is born with defective thyroid hormone production and the patient is having hypothyroidism. What do you expect that this person is gonna have in the future if you give this person thyroid hormone? So if you give this person thyroid hormone, this patient is going to be completely normal, right? If you give a patient of hypothyroidism thyroid hormone, the patient is going to be completely normal. He's going to have completely normal brain function and the brain maturation is going to be completely normal, right? Now, the second thing that is very important is that thyroid hormone has beta effects, right? The thyroid hormone has beta effects. Why is this thing important, right? If you remember if you remember our second lecture or the year, so it was the first lecture. If you remember our first lecture of cardiovascular physiology, you are gonna know that I told you that whenever something acts on the beta receptor, it's gonna increase the protein kinase, right? It's gonna increase the protein kinase, right? So uh, whenever you are having a person and that person on that person's beta receptors, beta something binds, the patient is going to have beta 1 receptors in the heart and that is going to activate, right? So now what is going to happen is that there are some effects of the beta 1 receptors that you're going to keep in mind. So I'm in a step one group on I'm an admin of a first one step one group on the Facebook, and I remember that somewhere over there a person was asking, so there was a page on the first chat, right? So I think it was this page, right? Let me open up the page, right? So it was this page, right? So it was the German pharmacology. A lot of students find it very difficult, right? And someone is asking, how can I remember this page, right? So how can I remember these pages, the sympathomimetics, right? So people find it very difficult. So you cannot just remember and cram it this page. So whenever you're doing different systems, you are doing different drugs. At that point, you are gonna remember these things, right? At that point, you should remember these things, right? So remember, whenever the beta 1 receptors are activated, you are gonna get an increase in the heart rate, right? And that is maybe due to hypothyroidism. You are gonna get an increase in heart rate, you're gonna get increase in cardiac output, the stroke volume is gonna be increased, the contractility of the heart is gonna be increased as well, right? All of these things are gonna be increased when a patient is having thyroid hormone access, right? So that is why when we so they could ask you another question. So if a patient is having thyroid storm and we give a patient beta blocker, how does a beta blocker alleviates the symptoms of thyroid storm? So it alleviates the symptoms of thyroid storm or thyrotoxicosis by two ways. First of all, it's gonna block the beta 1 receptors. Secondly, it's gonna block the 5 prime deiodinase, right? So it's gonna act at all of those things, right? Now, this next thing that is important here is that a lot of our body's metabolic rate. So whatever we eat. So if you remember, if you know that some people get fat very fast and some people get fat very slow. So some people eat a lot of food and they do not get fat. Why is that so? Because we all of have a rate which is known as the basal metabolic rate, and that basal metabolic rate, believe me or not, depends on one of the major things, and that is the sodium potassium ATPase pump, right? So sodium potassium ATPase transport sodium into the out of the cell and potassium into the cell, right? So this is a sodium potassium ATPase. The more is the activity of sodium potassium ATPase, the more energy you are going to need, right? So what does thyroid hormones do? So thyroid hormone goes into the nucleus, It acts on the nucleus. It increases the sodium potassium ATPase. When you are having more sodium potassium ATPase, you are going to have more energy consumption, right? And whenever you are having more energy consumption, you are going to have increased body temperature, right? You're going to have increased body temperature. You are going to have more CO2 formation, and in order to remove that CO2, you are going to need more amount of respirations, right? So this is how thyroid hormone increases the basal metabolic rate. At the same time, thyroid hormone is going to increase the blood sugar levels as well. It's going to decrease the blood lipolysis as well, right? Okay. So any questions till now?
Did
Okay.
you
So
say thyroid hormone is going to decrease the blood sugar level?
what?
I didn't get the last statements you mentioned about thyroid hormone.
Yes, so thyroid hormone also increases the blood sugar levels. So, because thyroid hormone is going to increase the glycogenolysis and it's going to increase the gluconeogenesis as well, right? So, it's going to increase the glycogenolysis, it's going to increase the gluconeogenesis as well. So, in both of these ways, it's going to increase the blood sugar levels, right? Okay.
Okay.
Okay, now let me check more things. Okay, so doctor is applying the hormone in form of levothyroxine happens from the year kind of yes. So in case of congenital hypothyroidism, if you give the patient levothyroxine, the patient is gonna be completely normal, right? It will cross the blood-brain barrier. It's gonna solve all of the problems. The patient is not gonna have any kind of problem in the IQ. But if 1 year has passed and the patient is still having the symptoms, you cannot control that. You cannot reverse the symptoms. You can prevent the symptoms. You cannot reverse the symptoms, right? Yes, Dr. Laiba.
Sir, you were talking about the BMR. I didn't get
Yes.
it. Could you repeat, please?
Okay. So BMR. So I told you that BMR of our body or the basal metabolic rate depends on. So the BMR or the basal metabolic rate depends upon a pump which is known as the sodium potassium ATPase pump. The more the activity you have for the sodium potassium ATPase pump, the more the pump is going to be activated, right? The more amount of oxygen is going to be consumed, and the more amount of CO2 is going to be produced, and the increase and the more respiratory rate you are going to have, right? So all of these things are going to be present, right? So this is a problem. So now, so this is how the BMR is going to be increased. Yes, Dr. Sana.
Dr. Moore, can you please repeat about 5' deiodinase? Is it present in every cell of the body, and how is it what are the factors that stop it?
Okay. So now, so remember the last step in thyroid hormone synthesis is the transportation and degradation, right? So there is so first of all, let me tell you about another thing, right? So there is a protein which is so when the thyroid hormone is produced, it's released in the body in the form of T4, right? So 80% is gonna be T4, right? 80% of the thyroid hormone is gonna be T4 and it's gonna go to the blood, right? It's gonna go to the blood. Right. Now, in the blood, T4 is going to combine with the protein, which is known as the TBG. So the protein is known as the TBG, which is the thyroxine binding globulin. Right. The protein is going to be thyroxine binding globulin. Right. Now, why is this important? This is important due to the fact that, for example, if a patient is having hypothyroidism or hyperthyroidism, right? We measure the patient's thyroid hormones. We measure the patient T4 and T3, and UWorld is very interested in this, right? NBM is love to test this concept again and again and again, and this is very high yield. UWorld love this as well, right? Because this is very important, right? Again, this is very important. What I'm about to say, right? So, for example, if you have 100 grams of this is an imaginary number, right? So if you have 100 gram of T4, right? So if you have 100 gram of T4 that is present in the cell, right? So if you have 100 gram of T4 that is present inside the cell, inside the body, right? Only 0.3% of it is unbound, right? So only 0.3 gram of it would be present in the blood, unbound, and the rest would be bound to TBG. So the thyroxine binding globulin. So 99.7 grams are going to be bound to the thyroxine binding globulin, and only 0.3 grams is going to be unbound, right? And we can only measure this amount of thyroxine and T4 in the blood. We can only measure this amount of T4 in the blood, and this is what we are going to see whenever we do a blood test of thyroid hormones, right? We are only going to see this amount, right? Now, one important concept here is that whenever a patient is using OCPs, so if a patient is using oral contraceptives, or if the patient is having pregnancy, in both of these conditions, the amount of thyroxine binding globulin is going to increase, right? So the amount of thyroxine binding globulin is going to increase drastically. When the amount of thyroxine binding globulin is going to increase, what do you think is going to happen to this 0.3 gram? Will it increase or will it decrease now?
Decrease.
So it's going to decrease, right? So it's going to decrease to
Decrease.
0.1 or 0.2, right? So now you're going to see artificially that the thyroid hormone is low in the blood, right? So you're going to see that the free thyroid hormone is low in the blood. So now if you do the test, you are going to see that the patient is having less amount of T4 or T3. And you're going to misinterpret or you're going to misconstrue that this patient is having problems with the thyroid gland, right? So, but this is not true. This all of this is happening due to pregnancy, which is going to increase the TBG. So that is why the patient is going to have increased amount of the thyroid hormone synthesis and the TBG is going to be increased. That is why whenever we do a pregnancy test, we are going to do the free T4 as well as the total T4 and T3, right? We are going to do the two free T3 and T4 and total T3 and T4 as well. Now, if we go to another condition, which is known as the nephrotic syndrome. So we have some conditions such as we have the nephrotic syndrome, and at the same time, we have chronic liver disease as well, or we have malnutrition as well. In all of these conditions, the body is not going to synthesize any thyroxine binding globulin, right? If the body is not synthesizing any thyroxine binding globulin, the free amount of thyroid hormones in the body is going to increase, right? And you're going to see the increased amount of free thyroxine binding, free T3 and T4, right? Okay, Dr. Lamis, yes.
Okay, doctor, if we have like less free T4, so the
Yes.
T4 the decrease in T4 will lead to decrease in T3, which is the active form. So at the end we have less active hormones. So we have
Yeah,
hypo
yes.
or not.
Okay,
The
so
total
now,
number,
now let me tell. Yes.
the total T4 will be normal as the bound is increasing and the free is decreasing, but the effective should be low. Or I'm
Okay, so
wrong.
now let me tell you what will happen, right? So now when the T3 and T4 was decreasing, now we are going to move to the regulation of thyroid hormone as well, right? Right. So
Okay.
now what is the T3 and T4 are going to be decreased, right? So remember, whenever free T3 and T4 decreases, that is the regulation of thyroid hormone, right? So now the body is going to sense this and the body is going to release TRH and TSH, and that is going to increase the thyroid hormone synthesis to balance that free T3 and T4. So in the end, T3 and T4 will be normal, but the total T3 and total T4 are going to increase a lot, right? So this is what is going to happen in the pregnancy, right? Did you get it?
Yes.
No, can you
Can you
please repeat it
explain again?
again?
So it's just
Yeah, it
Okay.
was
for like
confusing.
regulation.
Okay. So see this. See this thing. So for example, you are having T3 and T4, right? 99. So let's imagine 99% of it is bound and 1% is free, right? Now the important part is the free one, right? So just say that the body wants to have 1% free T4 and T3 at every time, right? And when, so if the T3 and T4 is less than 1%, if it's 0.8 or if it's 0.7%, the body is going to sense that. The pituitary gland and the hypothalamus is going to sense that, and it's going to secrete the TSH, right? And that is going to increase the thyroid hormone synthesis. Okay. So now, for example, you are having a patient who is having increased amount of TBG or thyroxine binding globulin due to pregnancy. Now, what is going to happen is that when the TBG is going to be increased, the free form is going to decrease, right? So you're going to have 0.5% free form, and the body is going to sense it as a problem, right? The body is going to say, I'm having a problem right now. So what is the body going to do? So the body is going to do one thing. The body is then going to increase the TSH, and that is going to increase the thyroid hormone synthesis, and it's going to bring the free levels back to 1%. right? So the free levels will be normal, but the total T3 and T4 is going to be increased because there is going to be increased thyroid hormone synthesis, right? Did you get it now? Okay.
Free.
Yes, I got it. Thank you.
Okay. So now in the blood, so now Dr. Stana, in the blood, we are going to have 5' deiodinase as well, right? And what is the 5' deiodinase going to do? All the T4 that is present in the blood, the free T4, it's gonna convert it into T3. And that 3 is gonna go, that T3 is gonna go inside the cell. And when this T3 is gonna go inside the cell, then that T3 is gonna act on all of the things. It's gonna act on the heart, it's gonna act on the lungs, it's gonna act on the nervous system, it's gonna act on the reproductive system, and it's gonna act on the metabolism. Right? And how does it act on the metabolism? Okay. Just wait a second. Let me mute Dr. Sana.
Oh, my name is Dwayne.
Okay. Sorry. So I just muted Dr. Sana. Okay. So now the thing that is gonna happen is, so this is how it's gonna work, right? So now let's move to the regulation, right? So what is the regulation of thyroid hormone? Okay, okay, just give me 1 second. Okay. So I was saying, now how does the regulation happens, right? So first of all, if the T3 and T4 levels are low in the body, right? If the T3 and T4 levels are low in the body, you're gonna get an increased amount of TSH, right? That is the first thing that is gonna increase the synthesis of thyroid hormone. So if you are having low amount of T3 and T4, that is gonna increase the TSH. This is known as the negative feedback mechanism, right? That is known as the negative feedback mechanism, right? So now the second thing that is important here is whenever the body is having any kind of a stress, or if there is extreme cold, right, the TSH and the TRH is going to increase. So first of all, the hypothalamus secretes the TRH. So the hypothalamus secretes the TRH, and that TRH leads to, so TRH stands for thyrotrophin releasing hormone, and that TRH is going to increase the TSH. And then the TSH is going to be increased, and that is again going to lead to increased amount of T3 and T4, and then negative hormone can affect that, right? Now, what are the things that decrease TSH release? So again, there are the three things that are important are dopamine. It is dopamine. There are steroids, and the third thing that is important here is the dopamine, the steroids, and octreotide, right? These are going to decrease the secretion of TSH, and that is going to affect the body. Now, why is this important, right? Why is this thing important? This thing is important, right? Okay. Now, what will happen is that when a patient comes to you and that patient is having increased amount of steroids, so what if a patient is having increased amount of steroids or the patient is going through Cushing syndrome, that is going to decrease the secretion of TSH. And when the secretion of TSH is going to be decreased, the basal metabolic rate in the body is going to be decreased. You will be burning less calories, and when you will be burning less calories, you are going to get fat. That is why steroids affect the whole body. Steroids are going to affect a lot of systems of the body, and in this way, steroids are going to do these things to the body, right? That was the first thing. Now, I have already told you how do thyroxine binding globulins increase the T3 and T4 levels, right? So this is how thyroxine binding globulins are going to increase the T4 and T3 hormones, right? So any questions till now?
Dr. Moss, thank you for explaining the 5 prime deadenase thing. But I was a bit confused because in first aid, it is they have mentioned 5 prime deadenase in effector organs and not in the blood. So that is why I was asking: is it present in every cell of the body or is it present in the blood?
Okay, so it is present in the blood as well, and it's present in the affected organs as well, right?
Thank you so much.
Okay, so I'll slow down as well, right? So it is present in the affected organs and it's present in the blood as well. It is present in both of these places, right? So it's present in the blood and it's present in the affected organs as well, right? Okay, now let's move to the other hormones. Yes, so antipsychotics. So what will antipsychotics do, right? So antipsychotics again. If someone was asking about antipsychotics, right? So antipsychotics are gonna affect the thyroid functions, but not to a very much great degree. They're gonna affect the thyroid functions, but the thyroid functions are not gonna be affected very much. Antipsychotics are more of a factor of a prolactin, right? Antipsychotics are usually affecting the thyroxine more than the other things, right? So they don't affect other things as much as they are going to affect the prolactin, right? So now let's move on to the reverse T3. It's what is reverse T3? Let's move on to reverse T3, right? So what will sometimes happens is that T4, sometimes T4, so T4 can be converted into two things, right? So T4 is the storage form, right? So T4 can be converted into two things. It could be converted into T3, right? So T4 could be converted into T3, and at the same time, T3 can also be converted, T4 can also be converted into the reverse T3, right? So when T4 is converted into the reverse T3, it blocks the T3 receptor, right? This thing blocks the T3 receptor and it does not allow the T3 to function properly, right? This is known as the reverse T3, right? Now, uh, let's do some. So now, wait a second. Okay, so now, wait. Yes, Dr. Lamis.
So, Doctor Muaz, when is reverse T3 produced? What's the reason
Okay,
why it is?
okay, so do you want me to go into the details of reverse T3 now, or so it's a whole lot topic of the pathology, right? So I was thinking that uh, when we discuss the pathology, we'll go into it, right? Along with the euthyroid 6 sinus syndrome, right? So it's more important towards that. But because right now we are focusing on the physiology, we are not gonna go towards that, right? But it's increased under certain conditions, right? When the body is under stress or the body is having metabolic changes or the body is very severe, there is very severe illness in the body, there is very severe starvation in the body is under chronic stress, you are having physical or emotional stress, you are having diabetes, you are having low iron levels, you are severely dieting, you are having a liver disease, right? In all of those conditions, the reverse T3 is going to increase. That is why, again, when you are dieting, whenever you're doing a crash dieting, whenever you diet a lot, whenever you exercise to a degree that you do not have any more energy left in the body, what is going to happen is that you are going to have a lot of reverse T3. And when that reverse T3 is going to be present in the body during the times of stress, it's going to block the normal T3. And I told you that the normal T3 maintains the all of the metabolic functions of the body, almost all the basal metabolic rate. So the basal metabolic rate is going to be decreased, right? So the basal metabolic rate is going to be decreased, and that is going to cause a lot of problems to you, right? Okay. Now let's move forward, right? So thyroid hormone is now completed. Now we are moving to the parathyroid hormone, right? So now we will move on to the parathyroid hormone, right? So what is the parathyroid hormone? So the parathyroid hormone is produced by the parathyroid glands. How many parathyroid glands we have? We have four parathyroid glands, right? The first thing that is important here is this. The second thing is that whenever we're having a thyroid cancer, so whenever we are having a thyroid cancer, we will be having we will be removing the thyroid glands, right? And parathyroid glands are embedded in the thyroid glands, and sometimes we artificially accidentally, iatrogenically remove the thyroid, the parathyroid glands from the thyroid glands, and that is going to produce hypoglycemia. Right. This is the first important thing. The second thing is that what does parathyroid hormones do? So parathyroid hormone is going to increase the calcium in the blood. Right. And how is it going to increase the calcium in the blood? It is going to increase the calcium absorption from the GI system. It's going to increase the calcium absorption from distal convoluted tubule. Right. So last time we discussed that ADH increases the absorption of water from the distal convoluted tubule and the collecting ducts. Today we are going to see that the parathyroid hormone is going to increase the absorption of calcium from the distal convoluted tubule, right? And it's going to decrease the absorption of phosphate, right? So it is a phosphate thrashing hormone. So see, parathyroid hormone has the form PTH, right? So PTH stands for phosphate thrashing hormone. So keep this in your mind. So parathyroid hormone, whenever there is in excess of parathyroid hormone, the phosphate is going to be thrashed. The amount of phosphate is going to be decreased, right? So whenever you are having parathyroid hormone in excess, the phosphate levels are going to be decreased, the calcium levels are going to be increased. And now what is the pathophysiology behind this? How does parathyroid hormone decreases the phosphate level? Because it is going to decrease the absorption of phosphate in the proximal convoluted tubule. At the same time, parathyroid hormone increases the effect. So whenever we have vitamin D in the body, it comes in the form of 25 hydroxylase, right? This is known as the vitamin D. So vitamin D2. Now we are going to convert this vitamin into an active form. So in order to convert vitamin D into in its active form, we are going to add 1 alpha hydroxylase, and that enzyme is present in a lot of places, but it's also present in the proximal convoluted tubules as well. Right. So now there are a lot of conditions that can increase the vitamin D, and keep this in mind. Right. Whenever the vitamin D is increased in the body, there are a lot of conditions that can increase it. And one of that condition is parathyroid hormone overproduction. So whenever there is parathyroid hormone overproduction, phosphate levels are going to be increased. Vitamin D levels are going to be increased by how? Because proximal convoluted tubule is going to increase 1 to 125 alpha 125 hydroxylase, which is the activated form of vitamin D. Right now, I have another disease here, which is known as the sarcoidosis. Right. So we are going to go into the detail of sarcoidosis in the pulmonary system. Right. So in sarcoidosis, there is cough and there is increase in the calcium levels as well. But the important thing that you wanna guys keep in your mind is that whenever you are having the so whenever you are having sarcoidosis, how do the calcium levels increase? Because in sarcoidosis, again, the 1 alpha hydroxylase is going to be activated, and that 1 alpha hydroxylase is going to increase vitamin D levels, and then that is going to increase the calcium absorption, right? Similarly, whenever a patient is having any lymphoma, so for example, if a patient is having Hodgkin lymphoma, that again is going to convert the vitamin D into its active form, and then there is going to be hypercalcemia, right? Okay. So that is the first thing. The second thing is that PTH is going to increase the serum calcium, it's going to decrease the serum phosphate, it's going to increase the urine phosphate, right? And another thing is that PTH works by activating the CAMP levels, right? So PTH is going to increase the CAMP levels. And when the CAMP levels are going to be increased, the PTH is going to work. And it increases the CAMP levels in the urine, right? So so whenever a patient is having hyperparathyroidism, which means that the patient is having increased level of calcium in the blood or increased level of parathyroid hormone in the blood, the patient is going to have increased amount of urinary CAMP as well, right? So keep this thing in your mind, right? Now, uh, okay. So how is parathyroid hormone regulated? Right? So parathyroid hormone regulation is very simple. If you have decreased amount of calcium in the body, that is going to increase parathyroid hormone production. If you are having increased amount of phosphate, so increased amount of phosphate is a very big enemy of the body, right? It's going to go everywhere in the body and it's going to cause a lot of chalk formation throughout the body. So if you remember the chalk that you have seen in the real life, that chalk formation can happen in the body as well, and and phosphate levels are going to do that. So whenever there is increased levels of phosphate in the body, parathyroid hormone is going to be secreted and it's going to decrease the phosphate levels. Right now, two important things are present here. Right, and what is that? These are the serum magnesium levels. Right. So serum magnesium levels. Let's focus on the serum magnesium levels for a second. Or I think we should leave the serum magnesium levels for now and we'll focus it. Okay. So let's leave the serum magnesium levels for now and we'll focus it at the end of the lecture. Right. So, but remember one thing, calcium is the major regulator of parathyroid hormone release. Whenever there is calcium, whenever there is decreased calcium, the parathyroid hormone secretion is gonna be increased. Right. One more thing that is important here is the PTRHP. That is the parathyroid hormone releasing protein. What is this? Or the parathyroid hormone related peptide. Okay. So PTH-RPD is a peptide that is secreted whenever a patient is having cancer, right? So whenever a patient is having certain kinds of cancer, so if a patient is having squamous cell carcinoma of the lung or a patient is having renal cell carcinoma, then PTH-RP is going to be increased and it's going to increase the calcium levels in the body, right? It's going to increase the calcium levels throughout the body and it's going to cause a lot of symptoms of hyperparathyroidism, right? So this was the parathyroid hormone for now. The pathophysiology, we are going to discuss the pathophysiologies in detail whenever we are going to go into the pathology portion of it, right? And we are going to do the calcium hemostasis there as well, right? The calcium hemostasis is going to be done there as well. So now we are going to start the insulin. So any questions till now?
Can you please repeat the point about vitamin D activation, how parathyroid does that?
Okay, so vitamin D usually comes in the, so vitamin D is unactivated when it's come into the body, right? And vitamin D needs two hydroxyl groups, right? So if you are having vitamin D, if this is the vitamin D, you are going to need two hydroxyl groups. One is going to be present on the 25 side and one is going to be present on the one side. So one OH and the 25 OH, right? So the 25 hydroxylation is done in the liver. But after that, you need the 1 alpha hydroxylation. And that 1 alpha hydroxylation is done in the kidneys, right? So you need the kidneys to do the 1 alpha hydroxylation and whenever the PTH is present, then the 1 alpha hydroxylation is increased and the calcium absorption is going to be increased as well. Any other question? Okay. So now we are going to move to the, the most morbidiest hormone of today, of this 21st century, that is causing the most amount of problems, and that is the insulin, right? That is the
Can I
insulin. A
ask?
lot of you know. Yes?
Yeah, how do you relate with the magnesium PTH?
I did not get your question. I did not get your question. Can you repeat it?
How do you relate the magnesium level and PTH?
Okay, so I'm going to explain it at the end, or maybe I'm going to explain it when we do the parathyroid hormone diseases. So when we do the hyperparathyroidism, I'm going to explain it till then, right?
Okay.
Okay, so now we are going to do the insulin. So first of all, where is the insulin secreted from? So insulin is secreted from the beta cell of the pancreas, right? So the beta cell of the pancreas are going to secrete the insulin. That is the first thing that is important. Now, the second thing that is important here is, first of all, where in the beta cells are going to is going to the protein the insulin is going to be secreted. So the insulin is produced in the rough endoplasmic reticulum of the beta cells, right? So it is produced in the rough endoplasmic reticulum of the beta cells, and it's going to be produced as well pre-proinsulin, right? And then it's be, so now first of all, this is important, right? And I remember there are a lot of keyword questions on this as well. So in the beta cell of the pancreas, in the rough endoplasmic reticulum, we are gonna have pre-proinsulin, right? Why is this known as the pre-proinsulin? So remember guys, first step one is lot about the pathophysiology and the physiology. So we need to focus in these on as well, right? So the pre thing is known as the signal peptide, right? So it is known as the signal peptide. And what does this signal peptide do? This signal peptide is gonna send the insulin to secretory granules, right? So when it will be present in the secretory granules, it's gonna be known as the proinsulin, right? So the pre-proinsulin is gonna become proinsulin when it is gonna be present in the secretory granules. So the pre part is going to be removed when it transfers from the ref endoplasmic reticulum to the secretory granules, right? Now, after that, the proinsulin is going to be cleaved, right? So this is going to be converted into two things, insulin and the C peptide, right? It's going to be converted into the C peptide, right? Why is this important? The C peptide represents the insulin production is happening inside the body, right? So if you check a patient and you see that patient is now having insulin and C, so now if you check a patient is having increased amount of insulin and you want to know that whether this insulin is present inside the cell or whether this protein is present out of the cell, right? So you want to see that whether the insulin that was given to this person, was this insulin coming from an exogenous source or was this protein coming from inside the body? So for that we use the C peptide. Why? Because the patient may be having an injections of insulin, right? Bodybuilders usually use insulin for muscle growth, right? Now, some people use insulin to fake their illnesses, right? So, for example, if there is a worker in your office or if in your hospital and that worker wants to get extra sympathy, he's going to inject a insulin injection in himself, right? Or she's going to inject an insulin injection in herself, and then the glucose levels are going to be reduced, and then the patient is going to faint, and a lot of people are going to be sympathizing towards that person, right? Now, how can you differentiate between these two things? So, you can check the C peptide levels. If the patient has injected insulin, the C peptide levels are going to be very low, right? Because C-peptide is secreted when the patient is having insulin inside the body. Whereas if a person is having insulinoma, which is an insulin tumor, then the C-peptide levels are going to be increased, right? Then the C-peptide levels are going to be increased and the insulin is going to be increased at the same time, right? So that is how we differentiate between insulin that is present inside the body, whereas the insulin that is present from outside the body. Again, if you are giving the patient a drug which is known as the sulfonylureas, so what do sulfonylureas do? We are going to go into the detail in the pharmacology portion, but right now, remember this thing, sulfonylureas are going to increase the amount of insulin inside the body. It's going to increase the insulin production, and when the insulin production is going to be increased, you're going to see that insulin production through the increased level of C-peptide and the increased level of insulin as well. Right now, insulin is secreted in the pancreas and it's cleared by both liver and kidneys. Right? Why is this important? This factor becomes important due to the fact that, for example, if a patient is diabetic, a lot of diabetic patients have kidney diseases as well. A lot of diabetic patients have liver diseases as well. So you calculate a dose of insulin and you think that a normal person should have 10 units of insulin, right? Now, these 10 units of insulin are going to be cleared by the liver and kidneys. So, for example, let's imagine that this patient is having chronic kidney disease, or if this patient is having chronic liver disease. Now, if the patient is having chronic kidney disease or chronic liver disease, what is going to happen is that the insulin clearance is going to be low. All of the insulin is not going to get cleared in this patient's body. Cleared, the patient is going to get hypoglycemia. Remember, the most fatal effect of insulin is hypoglycemia. The most bad effect that insulin is going to have on the body is hypoglycemia, right? So whenever a patient of insulin, so whenever a patient comes to you and that patient is having hypoglycemia and that patient is diabetic, first of all, look at the kidney function test and the liver function test, because in the insulin is going to be going to be get cleared by the liver and the kidneys. So if insulin cannot be get cleared by the liver and the kidneys, then it means that the patient is having problems, right? So how does insulin works, right? So first of all, I told you that thyroid hormone works by binding the nuclear receptors inside the nucleus and increasing the protein production, right? Now, how does insulin works? So insulin is going to bind the tyrosine kinase receptors, right? So insulin is going to bind the tyrosine kinase receptor, right? And then it's going to do two things. So when the insulin binds the tyrosine kinase receptors that are present here, insulin, there is a protein, there is a vesicle which is known as the GLUT4 vesicle. So this is a glucose transporter 4 and it's gonna go here and it's gonna produce and it's gonna take the glucose inside the cell. So that is how insulin is gonna reduce the amount of glucose in the blood and it's gonna increase the amount of glucose in the body, in the cells, right? So GLUT4 are present in two places. It is present in the adipose tissue and it is present in the striated muscles as well, right? The one important thing that is present here, so insulin can increase the amount of GLUT4 in the cells, right? Another thing that can increase the amount of blood flow in the cells is exercise, right? So for example, if that is why we say that if a person is having diabetes, if a person is having insulin deficiency or any disease, how can we treat the patient is that we can give the patient exercise. We can ask the patient to do exercise, because whenever the patient is going to do exercise, the blood flow levels are going to increase, and when the blood flow levels are going to increase, the patient is then going to get reduced amount of glucose and the patient condition is going to be better. That is why exercise is so good for our body, right? Now, there are a lot of anabolic effects of insulin as well. It's going to increase the glucose transport, it's going to increase the glycogen synthesis, it's going to increase the triglyceride synthesis as well. So, when it's going to increase the triglyceride synthesis as well, you're going to get fat, right? So, for example, if you're taking, so what are the, so it's going to increase the fat, right? Now, it's going to increase the protein synthesis as well, right? And it's going to decrease the lipolysis as well. Now, we'll go into the detail of each of these things in the diabetes portion. But right now, remember, insulin does not cross the placenta, right? Insulin does not cross the placenta. Glucose can cross the placenta, but insulin does not cross the placenta, right? Why is this thing important? Okay, so let's go over this. So imagine, okay, but before that, okay, so for example, imagine you are having a mother, right? So you are having a mother. So imagine you are having a mother, and that mother is having diabetes mellitus, and she's having a baby as well. So when she will be having baby and she will be having diabetes mellitus, she would be going through hyperglycemia, right? And her amount of glucose is going to increase in this inside the body. And when the glucose levels are going to increase inside the body, then that glucose levels, then that glucose is going to go to the baby, right? So if this is the baby, the increased amount of glucose is going to go to the baby, right? The glucose is going to go to the baby, but remember, insulin cannot transfer the placenta and go to the baby. So what is going to happen is that in the early trimesters, in the first trimester, when the baby is not going to have any pancreas, all of that glucose, all of that nasty, crappy glucose is going to go to the baby, right? And the baby is going to have defects. The baby is going to have disastrous effects, right? So, for example, if a mother is having diabetes mellitus and that diabetes mellitus is uncontrolled and that diabetes mellitus is present during the first trimester, during the first 12 weeks of the pregnancy, then the baby is going to have signs and symptoms that are going to be very worse, right? That patient is going to have signs and symptoms that are going to be very worse. The patient is going to have heart problems. The baby is going to have truncus arteriosus. The baby is going to have a lot of other things as well. The baby is going to have caudal regression syndrome. The baby is going to have ventricular septal defects. The baby is going to have neural tube defects as well. All of this because the excess glucose can cross the placenta, but feed insulin, but the insulin cannot, right? But now, for example, if the mother is having diabetes mellitus in the third trimester and not in the first trimester, then the baby is going to have pancreas. So the baby is going to have pancreas. And that pancreas is going to detect the glucose and it's going to form its own insulin, right? And the pancreas are going to hypertrophy, right? The pancreas are going to hypertrophy and they're going to secrete a lot of insulin. Now, what will happen is that whenever the baby gets delivered, the baby is born, the increased amount of glucose is going to go away. There won't be any glucose because the mother is not disconnected from the baby, but the increased amount of insulin or the hypertrophic pancreas are going to produce a lot of insulin and the baby is going to go into the hyperglycemia. Right. So whenever a baby born, whenever a baby is born, whenever a boy or a newborn gets born and his mother was having hypoglycemia and the mother was having diabetes mellitus and that baby now comes to you and that baby is having signs and symptoms of hypoglycemia, it is due to the fact that the baby is hypertrophied pancreas and that pancreas are forming a lot of insulin and that is leading to a lot of problems in the baby. So remember, so if you look at the first aid, okay, so if you look at the first aid, I think there was something regarding it here in the first aid. That is the cardiology portion. This was the endocrine portion, right? So if you look at the first aid, you're gonna see here that when you look at the insulin portion, you're gonna see that it just mentions that insulin does occur placenta and excess glucose and fetal. It's not gonna go into the all of the details that what is gonna happen there, what is happening. So you have to keep these things in your mind. You have to know all the details and all the explanations of all of the lines that are present in the first aid, right? Now, let us move on to the regulation, right? Now, regarding the regulation, remember glucose regulates the insulin. Greater is the glucose, greater will be the secretion of insulin, right? Now, another thing that is important is that oral glucose increases the formation of insulin, whereas IV glucose does not, right? Oral glucose increases the formation of insulin, and IV glucose does not. How is this thing important? This thing is important because, for example, if you are having a patient and that patient is admitted in a ward, that patient is admitted in an ICU unit, or that patient is admitted in your floors, and you are giving IV dextrose or IV glucose or IV sucrose to that patient is not going to have insulin formation, right? And then you are going to need to provide insulin on your own because oral glucose leads to the formation of increased insulin as compared to the IV glucose. That is why whenever a patient is hospitalized and you're not giving the patient enough food, the patient won't have enough levels of insulin in the body, right? Because in whenever you eat something in oral form, you're gonna form incretins, right? What are incretins? Incretins were not that important 10 to 15 years ago, but right now they are the most hottest topic of medicine in the world right now. Why? Because whenever you eat something, GLP-1 analogs, which is an incretin, that is gonna be secreted, right? What does GLP-1 analogs do? Whenever you are eating something after a meal, GLP-1 analog is going to be secreted, right? GLP-1 analog is going to be secreted. That is going to improve the insulin sensitivity of the body, right? That is going to delay the gastric emptying, right? That is going to affect these things, right? So now we have a drug which is known as Ozempic. So Ozempic is a G1P, GLP-1 analog. This is going to increase the satiety. It is going to increase the insulin sensitivity, and it is going to make a lot of problems easier for the patients, right? So, any questions till now?
So just tell about this Ozempic.
Okay. So I was telling you that sometimes in order to increase the insulin formation in the body, you are going to need GLP-1. So GLP-1 is an incretin. What does GLP-1 does? So first of all, GLP-1 is going to slow the gastric emptying, right? So what will happen is that you have a sphincter which is known as the pyloric sphincter, right? So GLP-1 is going to slow is going to contract this pyloric sphincter. When the pyloric sphincter is going to be contracted, all of the food is not going to go into the intestines, and all of the food is going to stay in the stomach, right? So you are going to have increased amount of food retention after eating something. So for example, if the food normally goes after 1 hour of eating, you are going to get the food away from the stomach after 6 to 7 hours now, right? That is the first thing that the GLP-1 thing does. The second thing is that GLP-1 increases the insensitivity of body to the insulin, and that is the major problem that a lot of people right now are having, right? They are having reduced amount of insulin sensitivity, right? And when the insulin sensitivity and the insulin resistance is increased, you are having diabetes, right? So what does Ozempic do? Ozempic acts on the GLP-1 receptors. It slows the gastric emptying. It increases the sensitivity of the body to the insulin as well. So it's not only going to solve the diabetes, it's going to reduce your hunger as well. And diabetic patients have to eat low. And when they eat low, the patient is going to have better outcomes of diabetes, and the patient is going to have less amount of cardiovascular problems as well. So nowadays GLP-1 analogs are the best drugs for controlling a lot of diabetic related complications, right? Now, okay, remember, so now brain is so okay. So if you look at the heart and I ask you what is the main fuel of the heart, so the main fuel of the heart is fatty acids, right? The main fuel of heart is fatty acids, but the main fuel of brain is glucose, right? Brain can only use glucose for energy, or it can use ketone bodies. Brain cannot use anything else for the body. Why? Because brain needs mitochondria. Brain do not have mitochondria. And in order to utilize the fatty acids, you need mitochondria because fatty acids undergo oxidative phosphorylation. So oxidative phosphorylation is a form of energy production in which you use oxygen to generate energy, right? Whereas brain does not have any mitochondria, the brain only uses glucose or ketone acids, ketone bodies in order to form uh, fatty acids, right? In order to get the energy from the body. Any questions? If not, we're going to move forward. Okay, so oral versus IV glucose. So I was saying that
Dr.
whenever
Max,
a patient is,
what did you
yes,
say?
Dr.
Main
Sana.
fuel for heart? What is
So
main
the main
fuel for heart?
so the main fuel for heart is the fatty acids, right? So the main fuel for heart is fatty acids. Okay. So that is why they say whenever you are medicine is so interesting, especially biochemistry. So that is why they say whenever you wanna lose weight, whenever you want to do diet, or whenever you want to lose a lot of weight, you should walk, you should do exercise, right? And you should do slow exercise in which your heart rate is between 120 to 150, right? Why? Because when your heart rate is between 120 to 150, then at that point you are having the maximum amount of heart engagement, and at that point the heart is using the maximum amount of fatty acids, and that fatty acids are going to come from your fat, so you're directly burning your fat from the body, right? So heart is going to use fatty acids for energy production, whereas the brain never uses fatty acids. The brain says I'm only going to use glucose, and that is why whenever you are having hypoglycemia, whenever you are going through a fast, or whenever you are not eating anything, you are not crystal clear on a lot of things, right? Why? Because you're not having enough glucose. Now, oral versus IV glucose, right? So regarding the oral glucose, the thing that is important is whenever you are eating something, you are releasing GLP-1, right? You are releasing the incretins, right? So you are having GLP-1, you are having the incretins, and that incretins are gonna increase the formation of insulin in the body, right? That incretins are gonna increase the formation of insulin in the body. Whenever you are giving the insulin in IV form, that is not gonna form incretins, and that is why whenever you are giving the patients IV glucose, that patient is not gonna have increased formation of insulin. So formation of insulin is maximum when the patient is jet acid. What is jet acid? Yes, so keto acid. So ketone bodies are another fuel for the body, right? So ketone bodies are another fuel for the body, right? So ketone bodies are a very great fuel for the body, right? Now, let me tell you one further concept. Uh, so we have a diet which is known as the keto diet, right? We have a diet which is known as the keto diet. Right? And one most important function of our body was the insulin formation, right? So whenever we are having increased amount of insulin in the body, so what if a person comes to you and so that person is having increased amount of insulin formation, that is going to lead to increased amount of fat formation in the body, right? That is going to lead to increased amount of fat formation. So what is the best thing to prevent the fat formation? The best thing to prevent the fat formation is to reduce the amount of insulin. So how can we reduce the amount of insulin? We can eliminate glucose from our body. Whenever we are eliminating glucose from our body, no more insulin is going to be produced, right? No insulin is going to be produced, and when no insulin is going to be produced, the fat formation is going to go down. That is why they say keto diet is the best diet to lose weight, right? Because whenever you're using keto diet, there will be ketogenesis in the body, and that ketogenesis is then going to provide fuel to the brain, and at the same time no glucose will be present, right? So you're not going to have any insulin, right? And pro-inflammatory state, so insulin is a pro-inflammatory hormone, right? Insulin is not a good hormone, right? So if you are having a lot of insulin in your body, the thing that you're going to have is a lot of inflammation in your body, right? You're going to feel tired, you're going to feel lagged, you're going to have a lot of problems in your body just because of a lot of insulin in your body. And whenever a patient is having diabetes, the amount of insulin in the body increases as well. That is why if you eliminate sugars from your diet, if you eliminate all the insulin increasing stuff from your diet, you are going to have a clearer vision, right? You're going to have a clearer brain, the brain fog is going to go away, and you're going to have a healthy body as well, right? So this is the whole concept regarding the keto diet. Okay, so now, okay, so now let's do a disease, right? So now let's do a disease which is known as the, or maybe we can do it in the pathology portion. So is anyone having any questions? Okay, no. So let's do the cortisol hormone. So what is cortisol? Cortisol is a hormone that is formed from the zona fasciculata of the adrenal glands, right? Remember, it's gonna form from the zona fasciculata, and it's gonna be transferred with the help of cortisol binding globulin. So CBG is gonna transform the cortisol throughout the body, and cortisol again are gonna act on the nuclear receptors, right? And whenever you are having chronic stress, the cortisol is gonna be increased, right? there is going to be cortisol resistance, cortisol is going to be increased, and you are going to have these problems, right? So how is cortisol secreted? Whenever you are going through a stress, the amount of CRH, corticotrophin releasing hormone, is going to be increased, right? And then that is going to increase the amount of ACTH, right? And that ACTH is going to act on the zona fasciculata, and cortisol is going to increase, right? And that increased cortisol is going to decrease the amount of CRH in the body. That is how cortisol acts, right? So increased amount of stress, it increases the CRH, that is going to increase the ACTH, and that is going to increase the amount of cortisol in the body. Now, what does cortisol do? First thing is that cortisol is going to increase the appetite. Second is that cortisol acts on the alpha 1 receptors, and alpha 1 receptors are present on the blood vessels. So, on the blood vessels, there were alpha 1 receptors, there were V1 receptors, there were B2 receptors, right? So, alpha 1 receptors, cortisol can act. Cortisol will act on the alpha 1 receptors, right? And at the same time, cortisol is going to increase the amount of alpha 1 receptors as well. And when the amount of alpha 1 receptors increases, then norepinephrine and epinephrine and all of the adrenergic hormones are going to bind on the alpha 1 receptors, and blood pressure is going to be increased, right? It's going to increase the insulin resistance as well, and it's going to lead to diabetes, right? It's going to decrease the amount of lipolysis, right? So you are going to have increased amount of fat in the body. It's gonna decrease the amount of lipolysis, right? The most important thing is that it decreases the fibroblast activity. So when the fibroblast activity is decreased, you are going to have poor wound healing, or the collagen synthesis is going to be low, right? You are going to have poor wound healing, and that is why whenever a patient is having Cushing syndrome and increased amount of cortisol in the body, that patient is going to have stria, the patient is going to have um, poor wound healing, the patient is going to have osteoporosis as well, right? So it's going to decrease the bone formation, it's going to decrease the osteoblast activity. At the same time, it inhibits the formation of leukotrienes. This is very important. Decreases the formation of leukotrienes, it decreases the formation of prostaglandins. So whenever a patient is having asthma, right? So asthma is due to the leukotrienes, right? So whenever a patient is having asthma, or a patient is having an inflammatory condition, this is due to prostaglandins. If you give the patient cortisol or steroids, these are going to be inhibited, and the patient is going to feel better. At the same time, it's going to inhibit the WBC formation, adhesion, and as a result, the patient is going to have immunosuppression. So this is helpful in a way that whenever a patient is going through organ transplantation, then the patient is going to have these effects. Right. So we will keep our discussion till here today, right? Almost all of the hormones are completed, right? So from tomorrow we are going to complete the pathology, and if anything is left behind of the physiology, we are going to cover it in the pathology portion, and we are going to cover the anatomy of the different so there is one page of anatomy, and we are going to cover it with the pathology. So in different diseases we are going to cover the anatomy as well, right? So the cortisol synthesis is very simple. If you are having a cortisol problem, what if we are having any stress, if there is stress in the body, what is going to happen is that the body is going to sense that stress, the body is going to increase the amount of corticotrophin releasing hormone, right? The amount of corticotrophin releasing hormone is going to increase. And when the amount of corticotrophin releasing hormone is going to increase, the patient is going to have increased amount of ACTH, and that is going to increase the amount of cortisol in the body, right? Mm, okay. Okay, guys. So let's take it to here today. Today's lecture got a bit large, but we had to cover a lot of things. So tomorrow we are going to start from the pathology. If you have any questions, you can ask me any question in the group, and I would be very happy to answer you any of the questions. Okay, guys. Take care. Bye bye.
Thank you.